Thank you, Dr. Rishi Raj, for giving me this opportunity. It is a pleasure to talk, and it was very nice that you consider that ocular pathologies and various diseases you have compiled, and there are speaker of the different issues in pediatric diseases. I will make it. I will make it. No, no issue. Okay, no issue. Uh, First of all, I owe my gratitude to my mentor and teacher. They are teacher uh, who taught us, Professor Amod Gupta, Professor I.S. Jain. And I also owe my gratitude to my mentor in pediatric cataract surgery. While I was working at Storma Institute, I also worked with Professor. I got opportunity to work with Professor M.E. Wilson, that initiated me into pediatric cataract surgery. Of course, Abhay Vasavada, I used to see and listen to him in various conferences. Why pediatric cataract surgery? Because childhood cataract is a avoidable cause of visual disability, and 10 to 40% of the childhood blindness is due to cataract. Most actually there are high complication rate after doing pediatric cataract surgery, such as PCO, glaucoma, amblyopia, and even blindness. So for me, most powerful draw uh, was to work on this field of pediatric cataract surgery, and I developed completely focused motivation and strong will to turn that into reality. While we see these children, they are the children with visually significant cataract, while parents bring them, and majority of them bilateral, and 10 to 15% of these children, they have unilateral cataract. While they are brought to us, then we document each of the child morphology of the cataract after dilatation, because it is not uniform that one type of cataract is there. It may be lamellar cataract, it may be lenticonus, it may be something else, or it may be PHPB. uh, so, and you can also rule out the various abnormalities, such as uh, subluxation or coloboma. You can see various these type of abnormality in these children. There are various issues of concern in children. One is it is a growing eye, so there is a rapid axial length growth in the first 2 years of life. There may be marked capsular fibrosis. Posterior capsulotomy and anterior vitrectomy we do in younger children, particularly up to 6 to 8 years age group. These children may be uncooperative for biometry. Spectacle compliance is also an issue, and of course we have to treat and manage amblyopia. Our goal in pediatric cataract surgery is clear visual axis, and that has to be long-term clear visual axis and visual rehabilitation. I will be showing videos. This is one classical case of zonular cataract. I am staining the anterior capsule with trypan blue dye. And size of the rexis is kept around 5 millimeter or so. Cortex is removed after doing careful multi-quadrant hydrodissection, and then we go ahead with the primary posterior capsulotomy. First nick is given with the needle cystitome, and it is completed. The size of the rexis is kept around 3.5 millimeter or so. And then limited anterior vitrectomy in the zone of rexis is done. And then we implant, in every case, hydrophobic acrylic IOL in the capsular bag. Although there are other locations where we can implant, we can capture also. But this is the first choice. And residual viscoelastic and any tag of vitreous is removed. And this is a which we want, that this type of rexis, but if there is a vitreous dragging, then we have to do remove the vitreous from that place, and ultimately you achieve this type of rexis. And here it is just another technique how we do toric IOL implantation. This is also a case of zonular cataract. We mark horizontal meridian and then stain the anterior capsule with the trypan blue dye. And remove the cortex from the capsular bag. And then implant IOL, and in a particular axis, which is a desired axis, using Callisto. It has to be perfectly aligned. This is another eye seen at the same time 3 weeks back, which was operated by us. And these children, they need long-term follow-up, which is must for these children, because IOL implantation is just the first step, and treatment continues for long time. You see this child, infant, operated in 1997, and that time I did primary posterior capsulotomy, anterior vitrectomy, and IOL implantation. And now 25 years after, he has completed his MBBS and is myopic by 1.5 and 1.25 diopter. So most importantly, the word of Ellis are worth remembering. Young children with an IOL in place are a unique clinical responsibility of an ophthalmologist, and long-term follow-up is essentially important. And we had a lot of, we did lot of difficult and different cases, which 3 times winner of ACRS Film Festival Award and 2-time Best of the Best Award. So thank you very much for giving me this opportunity. Actually, time shown was I think differently, so I skipped my presentation. We are already late also due to previous session.
Thank you so much, sir, for a wonderful talk. It's always like pleasure to listen and see to videos of sir. We have always been seeing, and it's always a learning and informative session. Sir, Dr. Shok Sharma, sir, you have also been doing many surgeries. Would you like to add something or in these cases?
I think sir has covered almost all the complicated issues with this topic, and he is the authority on that. I think I won't be able to add anything, but I think the patients who are having uveitis along with the cataract, probably a severe uveitis and healed uveitis, probably these are the patients where sir is doing even I think IOL in those cases, but others may consider secondary IOLs so that there is no complications. Because operating very young children, especially neonates, and putting IOL in that, sometimes you may have to do a lot of times multiple surgeries which are not good for corneal endothelium and ocular structures. So if one is not very sure if the eye is micro-ophthalmic or something, some other dysgenesis, maybe that better to put secondary IOL and manage aphakia with other modalities of treatment. I think,
Definitely, I think these children, they are different, such as microphthalmos, microcornea, and those patients such as JIA, uveitis cases, or subluxated cases. So everything complicated is not attempted because keeping in view the time.
Sir, one important thing, sir, you have been a lot of experience of toric and multifocal in children. So, what is, would you like to say, can we do multifocal ions in children?
Actually, it was selectively we carried out the study where in children more than 5 years of age, because younger children you can't do because there is a change in the axial length. After 5 year, change still occur up to I think even up to 12 years, and some little change from 12 to 18 years. So almost two-thirds of the children which we operated, they had they were independent of spectacles, but still one-third of the children required spectacles. But then it has to be done very, very selectively. It is not uniformly that all cases we go for these multifocal and trifocals.
Thank you so much, sir, for enlightening us.